of a 26-month-old female child, resident of Bahadurgarh, Delhi, presented to Kalavati Saran Children's Hospital 10 days back with the chief complaint of non-attainment of milestones since the age of 15 months, followed by progressive loss of attained milestones in the last 5 months. She also had episodes of vacant stare for the past 2 months. Child is fourth born to a non-consanguineous marriage and apparently well till 15 months of age. At this age, the child could cruise around the furniture and creep upstairs. He could imitate scribbling, could also feed from a cup with spoon with spilling. The child also could speak 1 to 2 words with meaning, to play simple ball games, and used to point to objects in which she was interested in, which seems to be appropriate for her age. However, the mother noticed that the child stopped gaining milestones thereafter. Even 6 months later, that is at 21 months of age, child could only do those things which he was already doing at 6 months of age. At this point, mother also felt that the child had diminished hearing in the form of not turning head to sounds and not responding to verbal commands, which she used to do previously. Over the next 6 months, child progressively lost her already attained milestones. In the initial 2 to 3 months period, she lost her ability to cruise around the furniture, her vocalization decreased, lost her interest, and she stopped interacting and indicating her needs by various gestures, which she used to do earlier. In the next 2 to 3 months, further deterioration in the milestones occurred, and the child was unable to sit, and she stopped waving bye-bye, stopped transferring objects from one hand to another hand, and eventually in the last 1 month of the illness, she further lost her attained milestones, and currently she is just able to hold her neck and hold rattle placed in her hand and coos and sometimes say agu and recognizes mother, and social smile is also present. The mother is saying that she makes eye contact when she is looked after, and hearing, as discussed earlier, is diminished as before. Also, for the past 2 months, mother noticed that there are episodes of vacant stare which are lasting for around 15 to 20 seconds, resolving spontaneously. It is not associated with frothing from the mouth, incontinence, abnormal body movements, and the frequency of these episodes, according to the mother, has increased over the previous 2 months. Initially, it was around 4 to 5 episodes, and now it has increased to around 10 to 12 episodes per day. There is no other abnormal body movements noticed by the parents, no history of abnormal eye movement, no deviation of the eyeballs, no difficulty in swallowing or suckling, no drooling of saliva, no deviation of the angle of mouth, no watering from the eyes. There is also history of activity and interest in the surroundings noticed by the mother, but there is no differential paucity in the limb movements. There is no history of excessive floppiness or tightness of the body noticed by the child. Cries on wetting of and is easily consoled by holding and caressing. There is no history of persistent fever any time during the course of the illness. There is no history of increasing head size noticed by the parents. There is no history of recurrent infections or previous hospitalizations for various illnesses. There is no history of sudden paleness or progressive paleness, blood transfusions, bleeding from any other side. There is no history of abdominal distension. There is no history of any bony abnormalities noticed by the parents. And there is also no history of skin or hair changes noticed by the parents. There is no history of abnormal odor of urine or body noticed by the parents. There is no history of TB contact. Then in the treatment history, child has been showing to government hospitals for the past 2 months. Some scans were done according to the parents, but they were not told about the diagnosis, and no treatment has been given to the patient. And for further deterioration of the milestones, child has been admitted at Kalavati Saran Children's Hospital for the last 10 days and has with the neuroimaging, and certain blood tests and lumbar puncture according to the parents has been done, and some of the reports are still awaited. However, the course during the hospital stay has been static for the past 10 days. In the developmental history, now I will be proceeding towards the developmental history.
You want to summarize?
Yes, ma'am. From the history, she's a 26-month-old girl child who presented with a complaint of initially for the initial 15 months, the child was attaining all the milestones normally. Then she followed a static course. She was not attaining any milestone which seemed to be appropriate for that age in the period of 15 months to 21 months. And then she lost already attained milestones progressively over the next 5 months. And now she's at the present state. There is also history of seizures in the past 2 months and hearing impairment according to the history. Though the vision seems to be appropriate for the age. And then further in the developmental history and developmental assessment, we'll try to jot down.
Does the mother feel that there is hearing, or you think there is, or she has definitely complained about the hearing?
Ma'am, she has definitely complained about it.
And she feels that the child cannot hear, or he doesn't respond?
Yes,
what is, how did you get this history?
Ma'am, initially the mother is saying that when she used to call the baby by her name, she used to turn her head. Or when there is a loud noise made at the home, she used to startle, or she used to make body movements. And eventually in the last 11 months, all these things have diminished. So she presented with this complaint only initially.
So she's not responding even to noise?
Even to noise. Loud noise.
Because language impairment can be there without the hearing impairment, I mean.
Yes, ma'am.
Because of cognitive involvement. So it's the noise also she doesn't.
Yes, ma'am. She's saying that. Okay. Ma'am, then proceeding towards developmental history. In the gross motor domain, the child attained neck holding at 4 months of age, rolling over at 6 months of age, sitting with support at 8 months of age, and sitting without support at 10 months of age, cruising around the furniture at 12 months of age, and at 15 months of age, she used to creep upstairs. And the mother is saying at present she is just able to hold the neck and turn over with difficulty. When she is placed, she is saying the turnover is there from prone to supine position, but it is with difficulty. So the developmental quotient of the gross motor domain turns out to be 20% for her, because it is around developmentally in the gross motor domain she is around 4 to 5 months.
Then to say that's formally assessed by proper developmental test. You're just taking the history.
Yes, ma'am.
And the regression you've already described. So all you need to decide here is the development till the on.
Yes, ma'am. Yes, ma'am.
And no calculate any detail.
And are you going to tell us about the current functioning level, all the things right now here, or you are going to tell us later?
Ma'am, I will tell right now here, and also in the examination in the development we'll try to confirm it.
Okay. Even in the history at the end, you should have what all is the child able to do? What is the functional status of the child?
Ma'am, I've told that she's able to hold the neck. She's able to play with the rattle placed in her hand. She's not able to turn head to sounds, and she is able to have social smile and recognizing mother.
How does she communicate about her needs?
Ma'am, she's saying initially she used to have various gestures, and she used to point to the objects in which she was interested in, but eventually she lost this ability, and at present she is saying when she is hungry she cries. Probably she is attributing it to hunger and the various needs, but otherwise all the gestures which she used to make earlier has lost in the preceding time.
But she can take, there is no problem in eating, feeding.
Yes, ma'am. Yes, ma'am. She is on top breastfeeding also, and according to the mother, she is not having any difficulty in swallowing or suckling or feeding, coughing during feeding, regurgitation of feeds. There is no history like that. There is no feeding problem.
And when she is crying or she is in wet, does she tell about?
Yes, ma'am. Whenever she is wet, whenever there is touch by the mother and caressing and consoling is there, she responds to that. So probably sensory system is intact. And when
vision?
Vision, according to the mother, she follows the things which she used to do earlier.
Same way.
She's not turning the head, but yes, she's making eye contact according to the mother, and she's also following objects.
Visual tracking is there till?
Yes, ma'am. Even further on in the assessment also it is there. And then proceeding to the fine motor domain, She used to reach out for objects with both hands at around 4 to 5 months of age, transfers objects from one hand to other at around 6 to 7 months of age, does not remember exactly when pincer grasp was achieved, but according to the mother, she used rice grains and all at around 10 to 12 months of age. She used to imitate scribbling at around 15 months of age. But at present, there is just bidextrous reach, which is there. In the key social milestones, social smile was attained at 3 months of age. She started recognizing mother at around 4 to 5 months of age, waving bye-bye around 10 months of age, used to play simple ball games at around 13 months of age, used to point to objects in which she was interested at around 15 months of age. And at present, she is just able to recognize the mother and social smile is there. She is not able to wave bye-bye, or there is no stranger anxiety according to the parents. In the language milestones, cooing was achieved at around 3 months of age. She was laughing loud at around 4 months of age. Agu sounds and monosyllables at around 6 to 7 months of age. Bisyllables at around 10 months of age. 1 to 2 words with meaning at around 13 to 14 months of age. At present, the child is just able to laugh loud, or cooing is there, and she is not able to say even monosyllables. Ma'am, then development that the child has global regression of the attained milestones, and there is no dissociative regression. Ma'am, then proceeding to the feeding history.
Birth history?
Yes,
Birth should come before development.
In the birth history, she is fourth by birth order, born to a non-consanguineous couple. During the antenatal period, there is no history of fever, rash, swelling in any part of the body observed by the mother. There is no history of drug or radiation exposure or any chronic illness. The mother was booked and immunized and were taking supplements and as advised by the doctor, and underwent scans which were told normal to the mother. According to the mother, they were normal, though I couldn't see the records. The baby was born single term with birth weight around 2.4 kgs via lower segment cesarean section. As mother is saying, there was non-progress of labor, and the baby cried immediately after birth, and baby was handed over to the mother on the same day, and breastfeeding was initiated the same day, and there was no difficulty in initiation of the breastfeeding, and no pre-lactate feeds were given. No abnormal movements of the body or yellowish discoloration of the body noticed in the postnatal period, and the postnatal period was uneventful according to the mother. And then proceeding to the child is primarily on milk and milk-based diet and is also taking egg according to the mother. And at this age, the requirement is around 1240 kilocalories per day, and protein requirement is around 14.9 grams per day, and she is taking around 69% of the required kilocalories, thus creating a deficit around 31%, and she is taking around 18 grams of the protein, thus creating an excess of around 20% of the protein.
You think the protein is going to cause problems if there is excess here?
Ma'am, if we are suspecting, there is no problem if she is taking.
What happens if you take more protein and there are less calories?
Ma'am,
yes? Proteins would be used for burning calories. Still he will be malnourished. Okay, so that's not the issue. Issue is, you said there is no feeding problem. It is not able to take enough. Why? Your history is inaccurate, or is it the problem in feeding?
Probably earlier she used to tell that she's hungry. Probably there is a communication between the mother and the baby. The baby is not able to tell when she's hungry, when she wants to stop getting fed, and when she wants feed exactly. That can be one reason.
What is the time it takes for her to feed? Is it prolonged and she is...
No, ma'am. According to the mother, the child is still feeding on breast milk, and it is approximately 4 to 5 times, and she's saying there is no difficulty at all. The thing that she's swallowing and suckling easily, and the time which she used to take earlier is the same as now, and I persistently asked
about solids. What about the solids?
Solids, maybe she's taking egg, butter roti, and also bread and biscuits, and she's saying there is no difficulty at all. Even
She's able to
yes,
chew
ma'am.
and swallow.
Yes, ma'am. With this deficit, I again directly
No
inquire.
issue of choking.
No, ma'am. No coughing, no choking, no regurgitation of feeds. There is no leftovers which the feed given to her is always completed according to the mother. Probably the needs of the child is not being communicated to the mother properly. Then proceeding to the family history, there is one history of abortion in the mother, which was around 4 months of age, and there is one history of sibling death at around 4 years of age of a male sibling, which was 2 years back. And according to the mother noticed a swelling at the back of the baby around 2 years of age, and then the mother is saying there was a history of trauma to the child when there was a fall of a bicycle over him. And she is attributing this trauma to the further neurological deterioration which the child had. According to the mother, after 2 years of age, after this trauma, the child had progressive neurological deterioration, and at the age of 4 years, the child was lost all the locomotor activity, and one fine morning, the child was found dead in the bed, and the cause is not known according to the mother.
I think we need to get better history than this for this child.
Ma'am, according to the mother,
Do you think it was a trauma which caused it?
Ma'am, according to the parents, they are attributing it to the trauma, but they went to one of the government hospitals, and where the scans of the brain and spine were done, the reports are not being told to the parents, but they were told that there is a problem in the brain and the spine which is there. The exact nature of the disease were not told, and they were told that nothing can be done about this problem.
But what aspects on history can help you decide whether it's because of the trauma or is it something else?
Yes, ma'am. Actually, it was a significant trauma because the mother is saying there was a loss of consciousness which was there for 4 to 5 minutes after the trauma, but there was no seizures or persistent vomiting after that. And according to the mother, they didn't seek any intervention at that time. They thought it is insignificant, and then after when the child had progressive neurological deterioration, then they
You have to qualify the deterioration.
Yes, ma'am.
How long did it take?
Yes, ma'am.
What was the final outcome?
Yes, ma'am. At 2 years of age, the child was able to walk, and the child was also interacting by ways and was using 2 to 3 words with meaning, according to the mother. But after that, the child progressively lost the ability to sit, stand, and eventually was she's saying the similar kind of illness was there as this child had.
Listen, what was the onset like? An acute onset. This you are describing as
according to the mother, it is a gradual deterioration.
It's unlikely to be because of trauma.
Yes, ma'am.
So don't just keep saying mother issues, mother.
Yes, ma'am.
See, it does, but what do you think?
Yes, ma'am. Yes, ma'am.
And was it involvement only of the legs, arms, brain? What all was he also having seizures? Did he have cognitive decline, or is it only motor?
Ma'am, there was no history of seizures post this illness, and there was gradual deterioration, insidious in onset in all the domains according to the mother, but there was no seizure. Ma'am, there is no history.
Finally, she thinks the child had similar illness.
Yes, ma'am.
But the hearing, what happened to the hearing there?
Ma'am, hearing, I didn't ask actually.
We can ask just now.
No.
You can ask just now.
तो एक बच्चा जो था ना जिसको दिक्कत हुई थी, तो उसमें सबसे वो चोट के बाद सबसे पहली चीज क्या गड़बड़ देखी आपने बच्चे में?
जब 2 साल पे उसको दिक्कत हुई थी, तो आप बता रहे साइकिल गिर गई थी उसके ऊपर और बेहोश हो गया था। उसके बाद
बेहोशी के बाद फिर से होश में आ गया था, चलने फिरने लग गया था?
नहीं, वो तो कोमा में चल गया था।
कितनी देर कोमा में था?
1
साल तक कोमा में था।
उसके बाद
कहाँ पे भर्ती किया था? रोहतक में दिखाया था। मतलब कि गिरने के बाद कोमा में गया था?
साइकिल गिरने के बाद।
तो कहाँ पे साइकिल गिरी थी? तो उसका ऊपर दिमाग का एक्सरे हुआ था? क्या बताया था डॉक्टरों ने? क्या कोई बोला था कोई खून जम गया है, कुछ बताया था? अच्छा अच्छा, तो तुरंत ही एकदम हो गया था साइकिल जिस दिन? कितने दिन के बाद?
कम से कम 2-3 महीने के बाद लगे।
2-3 महीने? क्या हुआ बच्चे को? 2-3 महीना तो कोमा में नहीं होगा ना बच्चा?
जैसे जब वो गिरा साइकिल हम उठाए एकदम नीला हो गया उसका मुंह।
अच्छा, फिर?
दिमाग दबाए फिर होश आ गया, बोला नहीं।
हाँ हाँ।
खाना हंसा।
अच्छा, फिर?
एकदम उठना बैठना सब कुछ बंद कर दिया।
अच्छा, फिर उसके बाद?
फिर उसके बाद वैसे सोए रहता था।
अच्छा,
तब हम लोग वहाँ रोटक दिखाए, बोले कि हाँ ये ठीक नहीं है कि बच्चे को।
नहीं पर तो 2-3 महीना तो घर में रहा ना बच्चा?
हाँ,
तो 2-3 महीना कैसा रहा वो?
वैसे सोए रहा था। हाँ,
खाना खाता था?
हाँ, खाना वाना सब कुछ खिलाते थे, दूध में सब कुछ खिलाते
पेशाब टट्टी कैसे करता था?
थे। ये सब था।
अच्छा, बुखार भी था उस समय उसको?
हाँ, बुखार आ जाता था। जैसे वो एक सप्ताह में
So what do you think now?
Ma'am, actually, when I took the history, this thing that the late intervention was taken after 2 months was there, but I asked that was there any bluish discoloration.
What if she told now? What do you think now?
Probably there was an acute insult and leading to vascular.
The child was at home for 3 months again is very unusual.
Very unusual actually. Father.
The child was so sick at that time that she's been in coma for 1
Yes,
year.
ma'am.
That means there was a life-threatening illness at that time.
Yes, ma'am.
So there is something which is unusual.
Yes, ma'am.
And I'm not sure whether she is getting the whole history.
And what was the swelling in the back? That would be
So, ma'am, actually, this was not by the mother which came after. This was by the father that the father noticed that when the child sits, I asked there since birth. He said it was not there since birth and there was no trauma to the spine. But when at the age of 2 years, when the child was sitting, the male sibling who expired, the father noticed that there is a swelling at the lower back, and for which basically they went to PGI Rohtak and got the
He
investigation.
was not sitting. He was, according to the mother, he was lying down in bed.
There is the father, the history which I got, because she was not saying all this. She was saying ki the child just had recurrent pneumonia and all. So probably.
Maybe we need to dig deeper into this.
Yes, ma'am.
और साइकिल उसके ऊपर कैसे थी? चोट लगी कैसे थी?
साइकिल वो चैन में लाता ना साइकिल।
हाँ.
ये इस पर धंस गई थी। जब उठा के फेंका देखी इस पर लगा था।
Extent of trauma doesn't seem so bad.
It's not trauma again.
वो जैसे बोझा कोई बगल में रखा था, वो साइकिल पर बोझा रखा था 50 किलो के।
अच्छा,
हाँ, तब हम बर्तन मार रहे थे, वो बोली कि हम खिला रहे हैं, आप बर्तन मार लो, हम उसको लेकर मार रहे थे।
तो बोझा इसके ऊपर गिरा था क्या? सिर्फ साइकिल गिरी थी? चेन गिरा था?
पूरा साइकिल गिर गया था बोझे सहित।
तो तुम 2 महीना जब तुम बच्चा था तुम्हारे पास, तो वो सांस वांस ठीक चलता था? देखता था बच्चा?
हाँ, देखता था। हाँ, देखने में ऐसे जब कुछ हुआ तो हंसता था बस।
हंसता था? कोई दौरा वगैरह तो नहीं आया था? कोई उल्टियाँ नहीं आई थी?
नहीं,
तो किसी डॉक्टर के पास नहीं दिखाया तुमने?
वहाँ रोहतक में दिखाया था।
नहीं, 2 महीने तक जो बच्चा घर पे
बीमार नहीं पड़ा।
बीमार
तो था ना?
जैसे वो इस समय बीमार नहीं पड़ा 2-3 महीने।
नहीं, पर बिस्तर पे था, चलना बोलना छोड़ दिया सर से।
तब उसी समय तो 3-4 महीने बाद ले गए जब हम तो बोले कि डॉक्टर को तक ले जाओ, क्या ये खड़ा नहीं हो रहा तो बैठ नहीं रहा।
Anyway, we should still think it could be something slow onset disorder which is affecting motor as well as cognition. Yes. Because if it was a trauma or it was some hematoma, it won't take 3 months.
Yes, ma'am.
Yes, ma'am. Unless it was some spinal cord or something which was involved, and then we can't make out anything. And I think the parents are unable to tell us.
Sometimes sudden deterioration after minor trauma is known in some degenerative disorders, like leukodystrophy. Example is that MS, megalencephaly leukoencephalopathy. The other one is vanishing white matter. So they can sometimes, even with minor trauma or minor febrile illnesses, have a sudden deterioration. So that is one sort of a possibility with deterioration after that. you want to put everything together, like this
Yeah.
child and that child together.
Definitely, it is not something as she first said that it is
Just
acute
not
because he was
acute.
there for 3 months. I mean, there is nothing, doesn't make sense.
Yes, ma'am. Ma'am, and according to the father also, the father noticed that the inability to stand was before the trauma. Yes, ma'am.
So
And there
in
is
that case, such a case, whenever you are presenting, don't go by one person history. You have to take the whole picture from both the parents. So some things are clouded by trauma. So if the child was unable to stand even before the child had a fall, so that is very significant. And you should not disregard that.
Ma'am, there is no history of deafness or blindness in the family. The other sibling is 9-year-old male child who is alive and healthy. And there is no, according to the parent, the child is have attained all the milestones normally and there is no problem. In the socioeconomic history, the family is a 8-membered joint family living in 8-room pakka house with head of the family being the father of the child, and they belong to lower class by modified Kupuswamy socioeconomic status scale. In the immunization history, the child is immunized till 15 months of age as per the mother, and after that they are saying because of the sickness of the child, the further immunization was not being done. So she is immunized till 15 months of age.
So, whenever we have a case like this, a neurological case, some of the key questions which come to our mind is, what is the onset like? Is it acute, subacute, chronic? What is the progression? What all parts of the process are involved? What is the likely etiology? What are the comorbidities? So all this you need to know. So if you start with the onset, what is the onset like? Any of you?
In this case.
In this case, yeah. It is insidious, a gradual onset. So more of a chronic disease. It's not an acute onset disease. What do you think was happening in that 7 months when the child was static? Are there some important histories we can think of at that time? You just said nothing happened, but what could?
Ma'am, there was
okay, nothing to happen.
Yeah.
She, according to the age from 15 months to 21 months of age, she should have attained the normal milestones which she should attain. So probably at that time there was a static course which was being followed, and after that, because of the further accumulation or deterioration in the neurological condition, the child regressed to what she is at present. So she followed a graph of initially following normal milestones, then static, then regressed to the.
Development has a graph which goes up. If it is even static, it is very, very worrying, isn't it? So between 15 to what, how many months?
15 to 21 months.
What all would he have increased? Explosive growth of vocabulary in this.
Yes,
and this child hardly spoke anything at all.
Yes,
so that itself shows that he was not developing. So it is, I would say it was already, disease had started before that.
So when do you think the disease started? 15 months. And progression? It is a static disease, progressive?
It's a progressive.
And so what all parts of the neuroaxis on history can we test? What all are involved? So,
Language, grey matter.
Okay. Seizures. So all these point towards
Grey matter
involvement. Yes.
What else? Motor milestones.
Milestones have also been lost. So, but there's no tone abnormalities in history. So hard to say. Remember that in all neurodegenerative disorders, it's the onset of abnormalities which may give a clue whether it's grey matter or white matter. In the end, the children all resemble the same. That's why the history is very important. In the end, the child will lose all milestones eventually. So in the end, it's very difficult to say whether it's white matter. So in this child, we're really not very clear. The only onset was that hearing problem which came.
Yeah.
Again, we're not sure whether it's a cognitive language issue or is it an actual hearing problem. The other milestones all seem to have been lost simultaneously. It's hard to say. In young children, sometimes it is hard to say. It is, especially this child at least is more than 15 months, but younger, less than 1 year of age, it's in them we really cannot differentiate whether it's a grey matter or a white matter disorder. Okay. Definitely white matter we're not sure. What other parts? Basal ganglia, is there any involvement or history?
Ma'am, there is no history of abnormal eye movements noticed by the mother. There is no history of abnormal
There's no
hand
history
movements.
suggestive of a
Yes, ma'am.
dystonia, abnormal postures and all. So it doesn't look like a visual ganglia disorder. Cerebellum? Anything you can take on history?
Ma'am, nystagmus, there is no history of abnormal eye movements, and according to the mother, the child is following objects. There is no jerky movements of the eyes which has been
It's
noticed.
difficult to
Yes,
exclude,
ma'am.
but at least it's nothing positive
Yes,
coming
ma'am.
out. So those are the first the things. And other associated symptoms, okay, what now comorbidities we talked of, seizures was one.
Seizures was one in
I
this
think
case.
seizures did not get that much
Importance.
importance in this history, which would. You just told us about vacant stares.
Ma'am, actually, according to the mother, what she told me that for the past 2 months, the child has vacant stare in the form of she stops responding, and this episode lasts typically for 15 to 20 seconds. And this thing was on direct inquiry actually, whether there is any abnormality in the. She didn't turn up. Directly with this complaint. This was on direct inquiry when she said that there is history of vacant stare which is lasting for 15 seconds and spontaneously getting aborted, and the frequency is increasing day by day over the last 2 months, and she's saying there is no history of associated frothing from the mouth or incontinence or jerky movements of the body, and according to the mother it is abnormal, so has been in the presenting complaint.
So what is the type of seizures you think?
Ma'am, absence seizures can be there or
Absence, but
Then
do
what do
absences
they
generally
occur in
present
this
in
also?
this age group?
no, ma'am.
In this kind of a condition?
So yes, they
Could
can
be
partial
partial
seizures,
seizures,
definitely.
right? Very right.
So absences usually occur, the typical absences would occur in completely normal children. Abrupt onset, abrupt termination, and older school age children, not in this age group.
Mostly primary generalized, it is if they're atypical absence.
They're otherwise normal children. Okay, complex partial or atypical absences, so those are the possibilities.
Yes.
Okay. So seizures are there. There are no feeding difficulties
There's
according
no-
to you, but the child is definitely taking less calories, so there
Yes,
must be some problem.
Yes, ma'am.
Vision is not involved.
According to the history, it is not.
Hearing?
Hearing, according to the history, it is getting impaired.
So, okay. So what about the likely etiology in this age group?
Ma'am, it is a progressive neuro-regressive disorder with hearing impairment with seizures, probably involving both.
Let them answer. Let them answer.
Anybody else can answer?
Srishti, बताओ.
She had attained normal milestones till 15 months, and then there was a regression, and we haven't checked the head circumference. So can we keep a possibility of Rett's in this?
Rett syndrome. Okay.
This is
There's
a
no history of loss of. There's no history of hand stereotypies.
What is the onset of Rett?
I mean, the child will have the normal attainment of milestones till 2.5 years, and then there will be regression of milestones, and the head size will stop growing.
Not till 2.5. They normal till the first, and then they
After
start
that.
deteriorating. And
It's
seizures,
earlier.
lot of autistic features. It's not at so late. Okay. Yeah, hand movements, hand stereotypies.
stereotypies. Yeah.
So the first of all, let us just say, okay, you said neurodegenerative disorder. The first question can be, is it a genetic or an acquired disorder? What do you think? Why? Yeah. There is a definitely family.
And that was a boy.
That was a boy. So it even gives you a clue as to likely inheritance. What inheritance would it be? Autosomal recessive. This is a girl, that is a boy. Both parents normal. Okay. But can there be any acquired causes which we need to look for?
Immune deficiencies.
Very good. Anything else?
So in the history, did we get enough this thing to say
Infections,
that
yes,
may not have been HIV?
Ma'am, in the history, there is no history of recurrent infections. She is recognizing her
Does
mother.
she have preferred the mother over somebody else, or she just?
Ma'am, according to the mother, yes, she is preferring mother over others. When I try to
Stranger anxiety?
yes, ma'am. Ma'am, but in the history she said there is no stranger anxiety. But when I examined, she said is there. I saw it is there. Maybe because I was there and was wearing a coat. Maybe. Ma'am, olfactory nerve could not. Bilateral pupils were equal and reacting to light. Direct and consensual light effects was present. On doing direct ophthalmoscopy, there was no optic atrophy or cherry red spots, which I could appreciate. Though I couldn't comment upon the retina and look for the retinal degeneration, which needs indirect ophthalmoscopy. Third, fourth, and sixth nerve, there is the range of the movements of the eyes apparently appears to be normal. The child responds to touch over face, and child is able to suck breast milk properly, so probably the fifth nerve is intact. And the child, there is no drooling of saliva or watering from eyes or in asymmetry of the nasolabial folds, which could be seen. And but the child was not turning head to sound, and there was no. Ma'am, child is swallowing breast milk properly and did not. So I didn't check for the gag reflex. She was swallowing the breast milk properly. There was no tongue atrophy or fasciculations or abnormal deviation of the tongue, which could be seen. Ma'am, in the posture, bilateral. When I examined, bilateral lower limbs were kept extended, and the upper limbs were flexed when I examined. Though right now she is playing with the rattle. Gait could not be assessed because the child is unable to stand. The bulk of all the muscles seems to be symmetrically reduced in all the four limbs, and there is no asymmetry in that. Tone appears to be normal in upper limbs bilaterally.
What do you think is the bulk of muscle is reduced due to?
Ma'am, because of the because severe acute malnutrition is there. Yeah. She's immobile. She's not having locomotor activity in the form of standing and walking.
Nutritional problem.
Nutritional. Ma'am, then the tone appears to be normal in bilateral upper limbs and increased in bilateral lower limbs. Power I couldn't assess. Cognitive decline of the patient. However, on painful stimulus, the power is at least 3/5 in all the four limbs. Because she can also watch the spontaneous movement. She is able to lift up her hand, hold the rattle, she is able to lift her legs. So yes, ma'am. You see that most of the group sits around at least 3/5. You don't always have to give a painful stimulus. Yes, ma'am. Ma'am, the DTRs were 2+ in the upper limbs, biceps were 2+, and knee and ankle was 3+. Ma'am, bilateral plantars were extensors, and primitive reflexes were absent. Child responds to pain by crying, and there is no nystagmus or tremors, or there was no meningeal signs which could be assessed. Ma'am, then proceeding to the per abdominal examination. The abdomen is soft, non-tender. Umbilicus seems to be normal and central. Hernial sites are free. The liver is palpable around 2 centimeters below the right costal margin along the mid-clavicular line, and it is firm, non-tender, and with rounded margins and smooth surface. The liver span is around 8.5 centimeters. And
the liver you said is firm?
Yes, ma'am.
So is it normal or abnormal?
Abnormal, ma'am.
So you think there is abnormal hepatomegaly?
Yes, ma'am.
Okay, go ahead.
Ma'am, spleen is just palpable along the splenic axis. In the respiratory system, chest appears to be normal in shape and symmetry. There is no obvious deformities which could be appreciated. Bilateral air entry is equal and vesicular breath sounds are present. No added sounds are seen, heard. Both the heart sounds are normal and there is no murmur. And then coming to the neurological developmental assessment, it was done in the presence of the mother when the child was happy and was not hungry, thirsty or wet. It is important that the child should be in a normal mood before proceeding with the developmental assessment. When I did the developmental assessment, on hearing the sound, the child quietened and stopped crying, but there was no startle to sudden sound which I made. And the child could not turn the head to the loud noise which was made.
But she is responding to
Yes, ma'am. Ma'am, in the developmental assessment, she is responding. Ma'am, when a red ring was shown to the child was fixing at it and was following up to the degree of 180 degrees. And also she was watching hands repeatedly. Probably hand regard is there. When I didn't give the rattle to the child, she was playing and constantly watching her hands. When a rattle was placed in her hand, she was playing with it for long periods, and on offering a cube, she was taking it, but was not transferring it from one hand to the other. And on offering a pellet, she was not trying to approach it. Yes, ma'am. I wanted to glass. Ma'am, glass. She was approaching it with the index fingers and was holding on the palm. It was immature.
Index finger.
Sorry, ma'am. With all the fingers and holding on to the palm. She was not using the thumb and the index finger.
She was not using the
yes,
thumb.
ma'am. And I offered a pellet also. She was not approaching it. Now, on placing in prone position, she could lift the head off the surface and was bearing weight on the forearms, but was not able to roll from prone to supine position. When she was made in the prone position for approximately 5 minutes, she was in prone position, but she was not able to turn to the supine position. And when a rattle was placed above her head, she was not creeping to pick the rattle. Now, on pulling the child to sitting position, there was no head lag, and she could sit with one hand held on her back, but was not able to sit unsupported. On holding the child in standing position, she was able to bear most of the weight on legs, but was not able to stand holding on to the objects with both hands. Ma'am, she was able to laugh loud at that time and speak Agu and was able to coo, but she was not using any monosyllables in the entire examination. Probably after developmental assessment, the developmental age corroborating with the developmental history, and it turns out to be 5 months, 4 to 5 months for this baby.
Okay, fine.
Yes, ma'am.
What else in anthropometry? Microcephaly.
It was brisk in the lower limb and normal in the upper limb.
Which is firm according to this may be normal in the SAM patient, but generally they have soft
Level. We'll have to check that out.
And
okay. And vision and hearing is normal.
And on development.
No involvement of vision, hearing, grossly. Okay. Okay. So can you first summarize it in very briefly summary, and then tell us what you think?
Yes, ma'am. Ma'am, 26-month-old girl child, fourth born of a consanguineous marriage with normal perinatal course, is partially immunized, is a case of severe acute malnutrition who presented with non-attainment of milestones since the age of 15 months and followed by progressive neurological regression for the last 5 months, with seizures for the past 2 months, with microcephaly, with mild hepatosplenomegaly, with apparently normal vision and hearing.
What disorders are coming to your mind? SAM is primary or secondary?
Ma'am, I think it is secondary.
It is secondary. So let us forget about the nutrition. That is not the primary problem for here. So let us focus on the primary problem. What is the primary problem?
And primary problem is neuroregression and also seizures for the past 2 months. It started with neuroregression and the seizures is there just for the past 2 months. So, and on examination there is hypertonia also. So tone and motor problems starting with at the age of 15 months is positive with normal perinatal events with probably of the similar illness could point towards white matter diseases. And the etiology, the exact cause is supposed to be found out in by further investigations, and later on maybe involving the grey matter also, because the child is having seizures right now. So eventually,
you should also talk about the family history, no?
Yes, ma'am.
There's a significant
family history also. So you please let us talk about that also. And then what disorders? Now name the disorders which you would think.
Ma'am,
at this point, at this age, which would present?
Ma'am, generally, we can, because there is microcephaly also on examination, and there is tone and motor abnormalities. We can think of metachromatic leukodystrophies. We can think of Krabbe's. Krabbe's is a white matter disease with microcephaly, and
so take all of them one by one and see the points in favor and points against. We'll see. So you think is MLD is one possibility, Krabbe's, anything else?
Then
we know any other possibility? MCL, okay.
There is no history of myoclonic jerks. There is no history
so we'll discuss each of them. We're just listing them now. MLD, Krabbe, MCL, anybody else? Glycogen storage disease, okay. Adrenoleukodystrophy, okay. Peroxide. Cell typer, okay, fine.
Okay.
But before that, anybody wants to think of other things? In this age group, what are the neurodegenerative disorders? Don't forget about grey and white matter. What is present at this age group? GM1,
gangliosidosis, Tay-Sachs can be there. Then Gaucher's, Niemann-Pick's.
Okay. In that group also we cannot totally leave.
So how many of these would have if you thought of hepatosplenomegaly, which one would be there? And if you didn't have hepatosplenomegaly, what would be there?
Ma'am, Tay-Sachs is there, then Gaucher's is there, ma'am, then Niemann-Pick's is there with visceromegaly, then various mucopolysaccharidosis can be there, but and ma'am, then
okay, so we have to think both ways, you know.
Yes, ma'am.
One is the age of onset, whether hepatosplenomegaly there or not there. I'm not sure whether it is there because it is a very...
one of them to...
Yeah.
Can you just check while she's feeding the child, be quiet, you can just check the hepatosplenomegaly.
Because means that's a very important thing to
Pointer
make it
for us to start.
Okay.
Start somewhere, okay. So with MLD, that was you said first. What are the points in favor?
ma'am, MLD, firstly...
Somebody else, Prabjot? Okay.
MLD matter disorder.
It's a white matter disorder, and by history we're really not very sure because it all started.
Everything will affect both
everything,
the whole
but
brain.
typically it's classified as a white matter disorder. But this child, we don't know if the motor, according to the mother, at least what she said, everything was lost together. So that doesn't help us. But the age at onset. Okay, so microcephaly doesn't usually occur. Okay. Any points other than in favor?
Ma'am, the favoring point.
Differential tone. Yes. So you can have mixture of findings, both hypotonia in the same patient, areflexia, hyperreflexia. So it has involved to the peripheral nerves also. You can have like only hypotonia with brisk reflexes. You can have hypertonia with depressed reflexes. Anything can happen. So this differential tone that also goes a little in favor of MLD. The pattern of inheritance, like it's a autosomal recessive, that goes in favor. But mainly age at onset, the most common form will occur in this age group, right? So that, but like microcephaly is not a part of MLD usually. It's not typical.
And which one is the most common type also?
Which is the most common type of MLD?
Ma'am,
late infantile. This is typical
age, 15 months.
Okay.
So you should go by epidemiology also in the population and what is the common variety that you can see.
So what about Krabbe? Anybody?
What is the age of onset of Krabbe?
Krabbe is usually earlier than this.
And how does it present?
Ma'am, irritability, failure to thrive, fever.
It's one of the early onset.
Early
First
onset,
year of
less
life.
than 1 year.
They have a lot of irritability, unexplained fevers, a lot of opistotonic posturing. They can have microcephaly. That fits in. That is also autosomal recessive. That fits in. And there are late infantile forms. So even if she has Krabbe's, it would be more likely to be a late infantile form. But they are uncommon as compared to the typical classic Krabbe. Right? So Krabbe also is associated with peripheral neuropathy. So that also explains our differential findings. Okay. Then third, somebody said NCL. So what about NCL? Yes, so that is the starting symptoms which this child didn't have. They have a lot of forces dominated
And
by
what
seizures.
is the most dominant? Yeah, seizures.
Myoclonic jerk, particularly.
Seizures,
myoclonic jerk.
all that didn't happen. And seizures are completely late in the illness, so we should keep it lower down. Okay. Then there was GSD. What type of GSD? Juhi, what GSD would you suspect? Okay, the type 1, does it have brain problems?
Which one? Neuronopathic. And what is the age of presentation?
Glycogen storage.
She's talking about Gaucher's.
I think you by mistake said GSD. We leave it out. GSD doesn't come anywhere in this. Okay, so Gaucher's can definitely. So type 1 neuronopathic Gaucher's.
What is the presentation of Gaucher?
Yeah, it's again that's what. It's early onset. They also have a opistotonic, posturing squint, stridor, retracted neck, and they have usually got a good sphenomegaly, sphenohepatomegaly, which this child didn't have. Bone marrow involvement. But and soft है firm है.
So 2 centimeters is abnormal.
It can be normal with
Can be
this
normal.
kind.
PEMD has happened.
Because he is also having
SAM.
and even up till 2 centimeters in infancy is normal.
It is okay.
You have to actually see the span and then decide whether it is really enlarged or not. Okay, so
We leave the liver out of our discussion. Okay, fine. Okay. So ALD. So I think आपने बताया अभिषेक ALD. Okay, so it will not occur in a female child. What else? So occur at this age. They usually occur, but the school age group children, 5 to 6, 7, 8 years of age, motor problems, behavioral problems. So those are the usual presentations.
And what else would you look in ALDs? What other systemic
Abnormal pigmentation because of retinal involvement.
Adrenal. Okay, so that also we have not seen any pointers. And the age of onset, I think, is the main thing. Main thing is age of onset. Is very
Even if you
important.
cannot tease out the grey and white matter, look at age of onset, look at organomegaly, coarse features. Okay, we've come to the other ones. GM1, what is points in favor?
Ma'am,
That's why I said coarse features, hepatosplenomegaly. Okay. Yeah, they again GM1. All these Krabbe, Gaucher's, GM1, GM2, they are all in the first year of life. Okay. So, but remember they can all have late infantile forms. So we keep them lower down. We don't totally take them out. Okay. Fine.
Anything else? Perioxysomal, somebody said. So what is the what is against Zellweger here and what is in favor?
facies is there.
Dysmorphic. They present right in the beginning. They have Downs-like features. They have dysmorphism, developmental delay rather than regression, right? So, and organomegaly.
I won't keep them.
You should not keep
Keep
it in
this list. Okay.
GM1, GM2, you should keep GM2. What GM2 is Tay-Sachs. So what can have?
Yeah, Tay-Sachs. How does it present?
Early onset,
cherry red spot in the eye,
and they don't have microcephaly. Again, this microcephaly is going again.
Enlarged head is there.
Microcephaly is actually going against all except Krabbe and NCL. So I don't know. And this, but overall also the child looks.
Supposing he had macrocephaly, then what would you think?
Alexander, Canavan, Tay-Sachs.
Okay. So this is the main things which help you. Our age at onset is the first, most important one. Then how did it start? Cognitive symptoms, seizures, more towards grey matter, motor symptoms, walking difficulties, more towards white matter. Then associated features like hepatosplenomegaly, coarse features, vision symptoms, seizures. So all these things and other features like hyperacusis that can be seen in some of these very exaggerated startle response.
Hyperacusis would be seen in which one?
Krabbe's image is there and
Also occur in GM1 and rarely in Krabbe.
Okay, classically Tay-Sachs. Yes. Okay.
So the answer should be the one which is most
common.
Rare वाले नहीं पता नहीं.
Okay.
So okay, so how will The NCL, that's what we said. NCL starts with seizures and vision impairment. The grey matter degenerative disorders. Yeah.
Child who is having SAM, and along with that we have microcephaly. Ma'am, should we take the length, the head circumference according to the length, or should we
SAM
take
does not affect the head growth
size?
Okay, severe acute malnutrition. Acute malnutrition, would it affect your head size?
No, ma'am.
No, it should not.
If we have a patient who is having a length which is short for the age, and we have a
Stunting
stunting के साथ में अगर microcephaly है मैम, तो should we interpret the microcephaly in according with the length?
Is there any chart for you which can interpret according to length? You have small children also having the same.
I think we were also taught that you should go according to the circumference for age, but some kuch people they've been told sometimes that they should be there are some length dependent.
See, it's a symmetrical IUGR.
Maybe for neonatology.
Neonatology, maybe it is different, but otherwise, and they will also measure. It will not come to -3 ST. There can be, I don't think so.
And by definition, child would be microcephaly. Whatever the cause, you have to say microcephaly.
Microcephaly, you don't have any other chart excepting by age.
By age.
Okay, and acute malnutrition should not affect the brain growth. And if it was, affecting, what is the head circumference?
It is 43.2.
43. What would be the normal child's head circumference? At what age would he have 43?
Around 7-8 months around.
He should be stunted also then, no? He is not even stunted.
Yes,
The nutritional causes won't cause this significant microcephaly. They can cause little bit of deterioration of your lower IQ scores or something, but not microcephaly. No. Unless there is some other gross nutritional deficiency that it should not
say nutrition.
Iodine deficiency or something, I don't know, prenatal acquired something, hypothyroidism. No, not like that. And if you would say like that, then somebody will say, how would you interpret according to length? We will get into trouble, so don't say that. HIV, very good.
I think still we should keep it. We should keep because microcephaly can all be part of HIV. Encephalopathy. Child has SAM, child has microcephaly.
What is against HIV here?
Ma'am, the family history, the mother is not giving any history of chronic illness during the pregnancy. She was booked and immunized, so she must have been checked for HIV at that time.
Plus, would have been how old?
Ma'am, 9 years and normal. And also the child, apart from HIV is an immunodeficiency disease. So apart from the global developmental delay, she is not having any kind of recurrent infections or recurrent hospitalizations or symptoms suggestive of HIV.
Right. So I don't think that again would be a very, especially because there are 2 children involved here, and that child would have been much, bigger at this stage, and the parents are asymptomatic, and the child is not having any infections or anything. Unlikely. But it should be kept if you have just come in any neuroregression.
Definitely.
So I think we should also go in for the investigations. What
investigations will you
because in this era, I don't think these are just to be thought about when you.
So you have to set of 5-6 differentials in your mind, but ultimately you have to investigate. You cannot stop. So what test would you like to do first?
Ma'am, in this case, we will try to go with neuroimaging because that it has been seen that different type of leukodystrophies and poliodystrophies, they have different pattern on imaging, and then we can go.
So what neuroimaging will you do?
Ma'am, MRI brain contrast.
You need a contrast
Yes,
ma'am. You don't routinely need it.
You don't need a contrast enhanced.
In all cases.
In which conditions do you need to have contrast enhanced MRI?
Infections and inflammatory
tumors.
Okay. Some of these, ALD has some contrast enhancement, but it's not a routine thing to give contrast. And I keep telling this to all of you because the cost increases exponentially when you ask for contrast. Okay. So a plain MRI suffices in most of the situations.
Unless you are thinking of MS or ALD.
Inflammatory conditions. Otherwise, no. Okay. So MRI should be the first. So do we have the MRI of this child?
Yes, ma'am. Yes.
Can you bring the MRI? Let us have a look at the MRI. इनको बोलते हैं वहाँ पे दिखा दें. Otherwise, you can speak. Just put it on.
So I'll first show you the a normal MRI, okay, so that you know what you're looking for. ये रहा, ये normal वाला है ना, इसे क्या आ जाता है तो टेबल पीछे ले आता, इसके ऊपर एक वो रख दो, पेन उस पेन ले था. See, basically in MRI you have two types of sequences. Basically you have a T1 and a T2, right? So the main thing you need to remember is that in T1 weighted image, the CSF looks black. Okay, you can see the. I hope all of you can come closer if you want. You can hold it. Yeah, sure. The CSF looks black. Okay, and the gray matter looks gray, and the white matter looks white. Okay, this is the normal MRI. So what are usually the parts that we look for is in white matter we look for the this is the periventricular white matter, all this. Okay, this is the corpus callosum. Posterior part is the splenium, the anterior part is the genu. Okay, you have the internal capsule, anterior limb, posterior limb, and you also have the subcortical U fibers. Okay, U fibers are these fibers which are just adjacent to the gyri and sulci. Okay, so many times मैं पीछे हो जाऊँ. दिख रहा है, ठीक है. So many times some leukodystrophies start with subcortical to peripheral to central. Okay, so typical one example being Canavan's disease that starts with subcortical and then you go on to central. Whereas MLD and Krabbe and ALD, they all start centrally. They start with periventricular and later subcortical fibers are usually spared till the end. Okay, so this is a T1 weighted image. I'll show you the T2 weighted image. In T2 the characteristics are reversed. Sorry, I'm so sorry. Okay. So this is the T2 weighted image. So T2 is what we need to look for all the leukodystrophies and all. In T2 the CSF looks bright. Okay, CSF, all these are the ventricles. You can see it all looks bright. This is the fourth ventricle here, right? So the CSF looks bright. The gray matter again looks grey, and you have the myelin or white matter which is black. This is a normal white matter which is white on T1 and black on T2. So if any abnormality occurs,
About the age.
okay. So usually,
by the white matter.
age also. In newborn period, it's totally unmyelinated brain, so it will all look again very bright. It will look abnormal. Okay. By the time a child is about say 6 months of age, some myelination you can start seeing. You can see the splenium gets myelinated first. Okay, and you have these myelination landmarks which I don't think you should know, but usually by 2 years of age the brain is completely myelinated. But remember, these little islands are left right till the end. The periventricular, many times you see this report of PVL, that's because of small, those can occur even till 30-40 years of age. So small little islands of unmyelinated white matter. Okay, so this is a normal child's MRI. Coming to this child, can I see the T1 first? T1, T2, yeah. Can I see the T1 first? This is. To me, yeah, okay. So, if you see
the first one,
so do you remember the second one?
Yeah.
So in T1 you really don't see very much difference probably, because as I said T2, in T1 abnormal white matter will look hypo intense. So if you see carefully, in that one it was much brighter. In this it is looking a little darker, but T2 you can see the difference much more clearly. In T2 weighted images, the abnormal white matter which was black in that image, you can see that it is hyper intense. Okay, and again if we want to see the pattern, it is, I think it's a late disease, so it has gone on even to the subcortical, and there is some cerebral atrophy also. So this is a sort of a late pattern. The corpus callosum seems spared. If you see the splenium is spared, the genu is spared, but the other rest of the white matter is involved. Okay. These get involved early in adrenoleukodystrophy. So there are some patterns. You don't need to remember all of them, but just to say that this is the abnormal there was abnormal brightness of the white matter is what you see, and you can also see, if you see carefully, there are certain stripe-like pattern here. Can you appreciate this? If you look carefully, stripe pattern here. This is actually called a tigroid pattern, and this is seen again in some leukodystrophies. MLD is one of them. Okay. So basically, this is the first step. So this looks like it's, at least we know it's a leukodystrophy. Okay.
And looking at the pattern, it is
Again likely
to be MLD. If it was ALD, distribution would have been different.
Okay. So any other tests we can do to ancillary test, confirmatory test?
No, ma'am, we have enzyme studies.
Confirmatory test. What enzyme?
Ma'am, aryl sulfatase A.
So any other ancillary test which will help you to support?
Ma'am, CSF protein. It is seen that it is elevated in cases of Krabbe's and MLD. And
it's elevated?
Yes, ma'am. In this child, we got it done, and it was around 102 for this child, which is, and there was no cells or sugar abnormality.
What are the tests one should do in white matter disorder?
Ma'am, in this case, we can go ahead with NCV also, because we are suspecting.
Peripheral and nerve is white matter is also involved.
Yes,
peripheral nerve.
What is white matter? No?
Myelin, yes, ma'am.
So myelin means it is there in the peripheral also as well as central. So you can do the electrophysiological nerve conduction study can be done for white matter disorder.
And then BERA and indirect.
So central pathway,
fundus, retinitis and all.
Okay. I think time is already, we've already exceeded the time, I think. Anything you So basically, but remember that after you have made a diagnosis, you can't just sit, because why it is important to make a diagnosis. The mother will ask you, can you help this child? What is the treatment? Shall I spend so much money on getting all the investigations?
Genetic counseling and the future pregnancies can be planned and can have prenatal diagnosis. Then also
prognosticate for the child as well as for the other children. You need to have a diagnosis.
Yes, ma'am.
And supposing it is there in the family, then the other child also,
Yes, ma'am.
So we have to see, and if they want to have another baby, because they have only one life, other than this. So it's very important to make a diagnosis, despite the fact that we may not be able to offer treatment. Because currently, do we have any treatment for MLD?
No, ma'am.
Experimental, nothing very standard care. We can't offer any treatment. But for certain
diseases
we do have treatment. So
like Gaucher, Fabry's.
So we have treatment, enzyme replacements are there. So we need to make a diagnosis. Most difficult part here is this mother, and I don't think we should speak it in front, but that is a special skill, and it's you have to learn how to do that, because it's a devastating for the family. We have two children who first was probably affected. The second one we know is affected.
Yes, ma'am.
So I think we'll stop here.
Thank you. Thank you.
Thank you. Thank you very much.
Questions on that?
Thank you.
Okay. Thanks a lot, Bhavna. Thanks a lot, Suhasini.
Thank you.
Thank you, ma'am.
For your
Bhavna did a good job, ma'am.
Yeah,
Thank you, ma'am.